Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So today I wanted to bring up a topic I haven't done in a while, and it's on shared visits. So the shared split visit that we are allowed to report from an inpatient, or I should say facility setting. So when the providers are seeing patients in the hospital, you can share a visit with a nurse practitioner or a PA, or what they call a qualified healthcare professional. So somebody who can report directly to a payer. So it would not be a shared visit with an RN or a technician or somebody that is not, another, again, qualified healthcare provider. But I wanted to make a distinction because there seems to be a I don't know if it's misrepresentation or misunderstanding that you can also provide shared visits in the office setting. And Medicare says, no, you can't. And it makes sense if you look at it from a couple of different perspectives. Number one, you cannot have a shared visit in the office because you can't have a new patient visit that could be billed out under the nurse practitioner or PA, or I should say performed by them and billed out under the provider, under the medical physician. So that's one reason why that doesn't work, is that in case the doctor isn't there or in case there's an issue, it doesn't work in the office. But when we talk about the office setting, we're talking more about incident 2. So there's so much confusion about incident 2 billing, and then is this a shared visit? It's really not the same. And I was actually reviewing an article recently in NAMIS as well that was talking about this. I've seen a couple of articles, and even in the most recent MedLearn Matters article that Medicare puts out, they were talking about this as well. And it was in the MLN 006764 E&M service booklet, where they were talking about the shared visits and the updates on that. So it's actually on page 19 if you downloaded the booklet from the CMS site. And I just thought it was interesting to maybe kind of revisit that, because there are definitely some misconceptions or misperceptions when you are dealing with shared visits that we really have to kind of bring together so people can understand what we're talking about on when you can actually get credit for it. And the reason I'm bringing this up at all is because I see a lot of shared visits in my auditing, and I don't see the FS, F as in Frank, S as in Sam modifier. It doesn't matter who the provider is. If you share a visit with a mid-level provider in the hospital, then you have to have the FS modifier. I also don't see a clear line of substantive information or work done by the physician to be able to get 100% of the reimbursement. Remember, it's whoever has the substantive amount of work. Otherwise, it defers to the lower valued physician is, or I should say lower valued provider. Sorry, I'm tongue-tied today. As far as who gets the credit. And they're reimbursed at 85% of the fee schedule, as you know, 85% of the allowable. So we have to be very clear when it comes to compliance on a share visit. So let me kind of go back to a couple things. So when we talk about incident 2 services in the hospital, we're referring to care provided by, again, that non-physician practitioner. We call them NPPs, that can be billed under the supervising physician's NPI, National Provider Number, at 100% of the Medicare fee schedule. Okay, so, and they get 100% allowable. But this is only permitted in the office setting and only when the NPP is following a care plan that was previously or already established by the physician. And again, that means it already exists. You're not actually executing it or making that care plan at a new patient visit. Do not believe that scenario. I read that on a site recently, and I'm like, oh no, that's wrong. So, you're executing as far as providing that service. The NPP is not establishing. So if they're establishing or anything needs to be changed, even as minor as an adjusting a dose, and I changed my stance on that because When you're adjusting dosages of medicine, that's changing what was already established by the physician. Now, if in, let's say, the initiating visit with the MD or DO, they said, we're going to try this medication, let's say it was on hypertensive medication, and we're going to try this medication and see how it works. And when the patient may come back in a follow-up visit with myself or with my nurse practitioner, and we may adjust depending on the reads at that time and the blood pressure log the patient's keeping at home. That's different because that's an established plan. But if you don't say that, then adjusting a dose is basically changing what's going on, and that's not following the care plan. The service no longer qualifies as incident 2 if you adjust anything, change anything, order anything. It's not a gray area. That's the rule. And, we also hear things like, and I see this when I go to the doctor. Well, the physician stepped in during the visit to create the plan. No. That only works if the physician's there to perform the entire visit, because the physician is only partially involved if that doesn't happen. Just enough to adjust a plan, initiate a plan. No, that's not incident 2. And you can't have a shared visit in the office because that's clear in the rules. So that's why, shared visits aren't allowed in the office setting. They're specific to facility settings, meaning hospitals or outpatient hospital departments where both the physician and the NPP see the patient on the same date of service. And the billing is based on, again, who provided the substantive portion of the visit, I can't say that enough, or who had 51% of the time. If you're in the office and the physician and NPP both contribute to the visit, you've crossed into a non-compliant billing situation, and now you don't even know if it's incident 2 or shared reporting to report. So what do you do? So you need to have a definite established plan in your office, clearly delineating what is what. Tell the providers, this is what incident 2 is. And you can find that on my website, terryfletcher.net, or if you're a member, I'll send it to you. And then what is shared billing? And again, I'll send that to you. And I've also have articles on my website explaining that. And I know I've talked about this on previous podcasts. But if there's no established plan, or the plan needs to change with the patient, the nurse practitioner PA should bill the visit under their own NPI. That's not only the compliant way, but that's the defensible documentation of what you can do should it ever be questioned from a legal perspective or a payer perspective from an office setting. Okay, so you have to make sure that you're not loosely interpreting anything that has to do with incident 2 or supervision that could jeopardize both not only your revenue but your credibility. Also, make sure you have a plan of what is shared visit, where if you have 2 collaborating providers in the facility setting, clearly demonstrate who did what, not just a canned smart phrase that says, I was there, I agree with the nurse practitioner, and we will proceed as follows. No, you can't. You haven't been able to do that for 4 years. So you have to be able to really understand what the specifics are when it comes to shared visits. Otherwise, you're going to have a real problem if this ever gets, taken to a different level as far as looking at legal, or it just becomes such an issue, and I just don't want you to ever have to deal with that. Now, what it says on the page 19 of the MLN 006764, it was July 2025. And I'm going to quote some things here. It says, facility setting is an institutional setting in which payment for services and supplies provided incident to a physician or NPP professional service is prohibited under our regulations. So they're saying you can't do incident 2 in the hospital. That's why we have split or shared visits. So the physician basically can't just be in the area, that you are actually both interfacing with the patient. It says a split or shared visit, E&M visit, that both a physician or NPP in the same group perform in the facility setting and in accordance with applicable law and regulations. It says either the physician or NPP can bill the service if they provide it independently, and then we pay the practitioner who performs the substantive portion of the visit. And it's just so clear. It says the documentation in the medical record must identify the physician and the NPP who performed the visit. The individual who performed this substantive portion of the visit and therefore bills for the visit must sign and date the medical record, and the designated modifier must be included on the claim to identify that the service was split or shared. It's also in the, for more information, you can look at the MM 13592 as well when it comes to split or shared, and look at the AMA guidelines and CPT. But they talk about this and they kind of update this information when it comes to split or shared. And the MM 13592 was the updated rules from January 2024. And they talk about, including this in critical care. They include this in SNFs. And you also have to meet the rules, on certain things where physicians must perform the initial in its entirety. But you have to be just cognitive of what the rules are before you just dive right in. I see a lot of things, again, in my auditing practices where I see that a lot of practices are still looking at the old rules where you can just sign off on it and say, I agree, and I'm done. And you can't do that. Billing and documentation is so clear that you have to meet the definition of split shared services. You have to use the FS modifier. Even if you are submitting the claim under the NPI of the MD or DO, you still have to have that if they had any input from an NPP. So it's just so important to make sure that you follow not only the documentation rules, the published guidance rules, but the billing rules. You're allowed to bill split or shared critical care services. Now, that was new as of 2024 on Code 99291 if you spend 104 or more cumulative minutes providing critical care. So you can't do it if it's just 30 minutes, only if it's 104 or more cumulative minutes, and you have to share it with a nurse practitioner or PA, and that's the FS modifier. And where the split or shared visit took place, no matter where it is in the hospital, you still have to document, and this again is in the MLN booklet, document and include the identity of both the physician and the NPP who performed the visit, the individual who performed the substantive portion of the visit, and then sign and date the medical record. It's just so important to make sure that you are clear that you aren't abusing this gift of being able to share a visit with another provider. And it's interesting because when they talk about the definition of substantive portion and they say more than 50% of total time or a substantive portion, underneath that they have this grid on page 20 of the MLN booklet. There is an asterisk that says you can't bill office visits or nursing facility visits at split or shared because Incident 2 is available in those settings. So then it goes back to Incident 2. And it also talks about time and qualifying time. You can count distinct time, you can only count distinct time for split or shared E&M services when the providers jointly meet with or discuss the patient. And then it says you can only count the time of one provider when they're jointly meeting. But again, that you have a lot of coordination, you have a lot of qualifying time activities that you need to list, regardless if it was involved, regular direct patient contact or whatever, but the clinical information, the appropriate exam, or the obtaining the history, reviewing the tests that you're not separately billing for. Similar to what you see in the office, but they want to see that. And you don't count time for travel, performance of other services you reported separately, as I mentioned, teaching that's general but isn't limited to the discussion of management and the patient. And then also there's a provision that says the time doesn't apply for critical care. Critical care is basically a time-based code, so you have to do basically time and then the critical status of what that was with the patient. So really take a look at that, and again, it would be page 19 to 21 in the MLN booklet, MLN 006764, and it'll really talk about what you need to do for shared or split visits. And it's funny because there's 3 different grids, and after every grid that gives you, this is what you code, or this is the code family, and this is what the substantive portion means, it has an asterisk underneath saying you can't bill office visits as split or shared. And so if they put it in there that many times, you better not do it. Now, what does that mean for everyone that goes to the office like I do, and I see the medical assistant. Of course, they try to get information. Then I see the doctor. Then the nurse practitioner comes in. So I see it in the office even when I go to the doctor, but they just can't count any of that when it comes to, there's no split or shared visits, just what the doctor does at that point. So to me, that's a waste of a very expensive employee. You got to be very careful with that. Okay, and I wanted to, finish up today on a somber note. I'm devastated, and I just want to send my thoughts and prayers, and my heart breaks, goes out to the family of conservative activist and actually a friend of mine, Charlie Kirk. It's hard for me not to choke up. He was assassinated on September 10th, and just being at a university, talking and having a conversation about things that may or may not be controversial, but having open discussion, talking about freedom of speech, trying to really, show our youth and kids of this country, just you have a voice, and to not be radicalized by some of the woke crap that's out there. And I'm sorry that I said that, but I'm just beside myself. I just can't even deal with some of the things that have happened. I mean, we've had 2 assassination attempts on our president, and those of you that know me know that I'm a conservative and I love this president. And we have had now just too many deaths, murders, now assassinations for people who are just trying to be good people. And I'm heartbroken. So just keep in mind that as people, as human beings, have compassion for, he was 31 years old. He has a 3-year-old and a 1-year-old son and a beautiful wife. And again, I knew him, and it breaks my heart that had to happen. So anyway, everyone, I hope that you never have to deal with that. And I hope that you have your voice heard when it comes to, just lead your life as a good person, as someone who upholds the values of what we have here in this beautiful country, and be careful what you allow yourself to believe that goes on outside of this country, because it's not what you think, So anyway, I try not to get political, but I'm very upset about this, if you couldn't tell. And I just hope you have a good rest of your afternoon. Thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.